well and look after their health and well-being. Now, in the long term, and as long as we can. We run a variety of evidence-based community programs serving schools, workplaces, councils, community groups, and more. This evening, we are delighted, as I said, to be joined by Dr. Alan Barclay. Alan is an accredited practicing dietitian who completed a PhD at the University of Sydney on the association between carbohydrate, starches, and sugars, and the risk of developing lifestyle-related diseases like type 2 diabetes and cardiovascular disease. He's also a qualified chef, co-author of more than 30 peer-reviewed articles and 5 books. He worked at Diabetes Australia, New South Wales from 1998 to 2014 as head of research, and the Glycemic Index Foundation as the chief executive scientific officer for 10 years, and is now a consultant. Now, Grant, you are absolutely wonderful, and can I thank you from the bottom of my heart to join us today in this. I know it was short notice, so I really, really appreciate it. Professor Grant Brinkworth is a senior principal research scientist at Csiro and board director at Glycemic Index Foundation. So you both must know my good friend Jenny Brand Miller. Yes, he has a PhD in nutrition and exercise science with more than 20 years experience leading large-scale clinical studies. His research interests include developing and translating effective nutrition, lifestyle and technology solutions for weight, metabolic disease, and type 2 diabetes management. Grant has published more than 100 peer-reviewed journal papers and co-authored 5 books. I tell you what, it's making me feel very, very, very inadequate, guys, with all of you being so fantastic and doing so much there. So, look, without me carrying on a little bit more, Alan, if you would like to kick us off by talking a bit about your work and current approaches to diabetes prevention and management. Ladies and gentlemen, can we please welcome Alan? Thank you.
Thank you very much. Thank you for the introduction and for the request to present at this conference. It's a good opportunity and I hope you all enjoy it. I do have a few slides to show. Hopefully they'll come up. Yes, this one's particularly dear to my heart. I started working at what was then Diabetes Australia, New South Wales back in 1998. And I remember one of the first conversations I had with the then CEO, Milton Noble, some of you might remember Milton, was at the rising rates of diabetes in Australia. And he showed me the latest NDSS, National Diabetes Services Scheme figures back then and said, look, you know, it's going up very rapidly and what can we do about it? Which got me thinking. And we certainly had a challenge ahead of us, but at the time, of course, the Heart Foundation tick was very popular and lots of people were asking us to do similar things on the labels for people with diabetes. In fact, they used to say, well, I have those foods with the heart tick and I measure my blood glucose and often they go quite high. So we need something for people with diabetes. And sort of putting 2 and 2 together, I guess we came up with the GI Symbol program, which I'm sure we'll talk about as we go along. So we can go to the next slide, please. So I'm not sure if everybody knows the equation as well as I do. So I just thought I'd put it up there to remind you because we'll be talking about it a bit, I think, based on the run sheet. So the glycemic load is the GI as a percentage times the amount of available carbohydrate, which is basically all carbohydrates minus dietary fiber in Australia. And maybe less well known is that 1 unit of glycemic load is equivalent to 1 gram of glucose. And I think it's important to keep that point in mind as we talk this afternoon. Next slide, please. So there's lots of debate and I've been around long enough to have seen it go full circle. When I was but a child in the 70s, low carb diets were very popular. I remember my mother and her friends saying you can't eat that potato because it's going to make you fat. It did stick in my mind as a child. And then, of course, we swang to fat being the demon in the 80s and back again to carbohydrates. And now, in fact, proteins become the demon, vegan versus carnivores, I think. But, you know, all these things don't exist in isolation, and it's important to realize that they both have similar, well, at least the amount and type, I should say, of carbohydrate have a similar effect on blood glucose levels. So Tom Oliver, who of course invented the GI when he was doing his PhD back in the late 70s and early 80s, has spent his whole life doing research on the topic and looked at the different effect of the amount of carbohydrate versus the type as quantified by the glycemic index. And really, you know, there shouldn't be any argument. The two are equally important and together explain about 90% of the variability in blood glucose after a meal. Now, the other 10%, of course, is fat, which does have a slightly longer term effect on blood glucose levels, and Carmel Smart's group's been doing quite a bit of research in that area. And of course, protein does have an effect as well, because certain amino acids are actually broken down into glucose as well. So, you know, it's not surprising that it's not 100%, but it's a pretty large proportion of blood glucose levels are described by the GI and total carb or the glycemic load. Next slide, please. Now, this was one of the papers from my PhD, published in 2008 now, and this was my first systematic literature review and meta-analysis. It was very popular at the time and still is quite well quoted today. And we looked at all of the observational studies, so the prospective cohort studies that were published at that point in time. I got every single one that I was able to find, and we looked at the best models within those cohort studies and looked at the highest versus the lowest quantile, and then looked at the relative risk between, in these examples, low versus high GI diets, basically. But importantly, as dietitians and nutritionists will all realize that the vast majority of these use food frequency questionnaires, where you have to remember what you ate over the past 12 months, which is not really that easy a task when you think about it. It's helped, of course, by prompts, and usually they're around about 100 to 150 items of various foods and beverages, but they're imperfect. The gold standard is still considered to be the weighed food records at this point in time. And when you compare them, they don't always tally up too well. In fact, one of my first chapters in my PhD thesis was to look at the validity of how these food frequency questionnaires measured the glycemic index and the glycemic load. And I was very surprised that at that point in time, nobody had even looked at that issue. So we did the first validity study. And then when I started looking at all of the published studies in the area, a lot of them just said, oh, well, we used a validated food frequency questionnaire, and sort of left it at that. But I had to scrape and look down further and find out, well, how were they validated and what exactly did they validate? And unfortunately, none of them have validated their ability of their tools to measure the glycemic index or the glycemic load, though some of them have done extensive work on total carbohydrates, and arguably that's a reasonable surrogate. So, but that was an important learning. So one of the things I set out to do in this systematic review and meta-analysis was only look at those studies that had validated the food frequency questionnaire sufficiently well to identify the GI and the GL of those foods. And you'll see why that's important in a minute. So if we can go to the next slide, please. So there was 37 studies overall, but a third of them they were very unlikely to be able to rank people according to their total carbohydrate intake. So really the tools, quite often they were designed for cancer studies back in the 1980s, and they were very fat focused and had very little detail about carbohydrates. Some of them said they were validated and they hadn't validated carbohydrate at all. And others were quite poor in the correlations between the weighed food records and the food frequency questionnaires. So the correlation less than 0.5 is pretty low. And when I excluded all of those and only included the ones that had at least a good chance of measuring the glycemic index and glycemic load, you can see quite clearly that there was quite a strong relationship between both of them. Anything over a relative risk of about 1.2 is considered to be reasonably strong for observational study. So both of these are well over that, and keep that in mind. Next slide, please. So just last year, we did an update with the rather ostentatious name, the International Carbohydrate Quality Consortium. I didn't think of the name, but a group of like-minded scientists from around the world who specialize in carbohydrates. So, and this one was, you know, it was like 12 years after my own systematic review, which was started in 2007. So we picked up a lot more new studies since then. Next slide, please, which is in fact a sub-study. Yep, pick that there. And you can see, and what we did again, we used the correlation between the weighted food records and food frequency questionnaires to basically sort the wheat from the chaff. So if you look at those that have a low correlation between the weighted food records and food frequency questionnaire, in other words, they probably don't measure carbohydrate very well, you can see there's essentially no relationship for GI and risk of type 2 diabetes. At 1.05 relative risk is quite small. Back, please. But when you include that variable, when you sort out the ones that aren't measuring carbohydrate well, the relative risk jumps up substantially and is now, of course, considered to be significant, 1.27. And if we go and look at glycemic load, we see exactly the same thing. So I guess the learning here is that just because it's an observational study, there's lots of people, it might sound impressive. Does the tool that they used to measure the dietary intake do it sufficiently well to really prove that there is a relationship? And I think, you know, if you just looked at the raw studies and did a tally, as some people are prone to do, you think, well, gee, it's rather confusing. There's no clear relationship between GI or GL and risk of type 2 diabetes. But when you look at the total body of evidence and filter it out by the quality studies, then there is actually quite a strong relationship. Next slide, please. Now, just pivoting a little bit, what does this all mean? Next slide, please. So I think you've all seen the National Nutrition Survey before. I won't need to go into the background details. Of course, it was quite a while ago now, and I suspect at least carbohydrate levels are lower and protein intakes are probably higher since then. You can see protein was essentially the same in grams, dipped a little bit as a percentage, increased a little bit as a percentage of energy. Alcohol went up slightly too. I think that's a confusing area in itself. I think less people are drinking, but those that are drinking more, which is one reason for some of the confusion that you see in the media about it. Next slide, please. Saturated fat has clearly gone down. So has total carbohydrates, 43.5% of energy. So Australians have a moderate carbohydrate diet now, less than the WHO's minimum recommendation of 45% of energy. And of course, that decrease was due to decreases in total and free sugars and added sugars, and also total starches. So all of the carbohydrate fractions have decreased. Now, I think the sad thing is, of course, dietary fiber is also a form of carbohydrate, a fact that's often overlooked, and that has also gone down as a consequence. And I think there is a little bit of a warning there because we didn't meet the RDI for that in the first place, even before the low carb craze. Next slide, please. So over the last few years, we've been looking at that data from the 95 and the 2011 and 12 National Nutrition Surveys. We have appended glycemic index values to the underlying AusNut databases and run it through the models. And we published this a couple of years ago now. Some people may have read it. You can see that there has clearly been a decrease in both glycemic index and glycemic load in the Australian adult population, and same in the children under 18, back please, population. And you know, it's due to a reduction in a whole range of foods, starchy foods as well as sugary foods. And I think it's not surprising when you think about what's been popular in the media over the past few years. Next slide, please. Now, diabetes prevalence has continued to rise since I had that first discussion with the CEO back in 1998, but it is actually starting to level off. And I think one of the reasons it is continuing to rise, of course, is because we're managing the condition better. People are living for longer, there's better pharmaceuticals, blood glucose monitoring is improving, and people in general, I think, are improving in health. The average lifespan of the population is going up. So one of the reasons prevalence rates are continuing to rise is because we're looking after it better. What you don't hear about, yeah, you can go to the next slide. And I've been liaising with particularly the Baker group down in Melbourne and Jonathan Shaw in particular to check these data. This is National Diabetes Services Scheme data, which is widely available. It's considered to be a reasonable surrogate for diabetes prevalence rates in Australia, and you can calculate incidence because they publish the data annually. And I believe the Baker is going to be putting out a paper on this topic soon. But you can see that diabetes incidence rates are actually dropping, something, of course, that you don't really hear in the media. But back, please. So, I think it's important to keep in mind there's lots of fear mongering about the diabetes pandemic and what have you, but part of the reason is because we're looking after it better. New cases do seem to be going down, which suggests that we are doing something good. And I would like to suggest that one of those things we're doing in Australia is improving the diet, lowering the population's glycemic index and glycemic load. Next slide. Now, as far as people with diabetes, it's surprisingly hard to find data on what people with diabetes actually eat. And this was, again, one of my PhD chapters where we looked at the Blue Mountains Eye Study cohort. So it was a cross-sectional analysis, in fact, back in the mid-1990s, so around that 95 National Nutrition Survey. And I think that's quite important because you can compare it to what people were eating in the general population at that time. And as you can see, protein intake was actually higher than the general population. Back, please. And carbohydrate consumption was lower than the general population at that time. So people with diabetes were already following a high protein, low carb diet in the mid-90s, let alone with the popularity of those diets over the past 20 years. And it would be really good to do some follow-up research in that group of people to see what they're actually eating, not what we're telling them to eat. And I think that's a big gap in the literature. And of course, there will be a new National Nutrition Survey. It was due to start this decade. I don't know whether it will with all of the COVID-19 issues, but let's hope that the government does see it as a priority so that we can get some more data. And last slide, which is just a declaration of interests, which I think have already been mentioned, so we can probably skip that one as well. Thank you for the opportunity again.
Thank you so much, Alan. I think we all found that, really fascinating, and it was really interesting to hear, not about the quality of the data and how that affects, what goes on in the media and things like that as well. So thank you very much.
My pleasure.
Now we will be moving on to hear from Grant, Professor Grant Brinkworth. So if you would like to share your screen, if that works.
Well, let's see if this works. Are we seeing anything?
Yes.
Cool, let me just make that big. All right, cool. Thanks for the opportunity, and it's always great to speak with Alan because I think what we share is a very similar message, and we're both passionate about diets with diabetes management. And so I thank you again also for the organising committee for giving me the opportunity to speak for a few minutes. So I was caught a bit on the fly, but I'm happy to step in for Barbara, and I hope you enjoy what I've got to say. So I'm going to sort of talk very much about where I've spent the last, 10, 12 years really on developing the Csiro low carb diet, which we feel is an evidence-based solution. And I'm going to sort of talk about some of the science that's behind that and some of the product initiatives that we've been doing. So what is the diet? It's actually an energy-controlled, nutritionally complete prescriptive meal plan that's actually based on whole core principles of healthy eating. And that's based on consuming nutrient-dense, low-calorie whole foods. But the dietary plan is lowering carbohydrate and higher in portions of protein and healthy, what we're calling unsaturated fats, and is still low in saturated fat, combined with a prescriptive home-based exercise program of aerobic resistance exercise. And the reason why we feel it's so effective is because it is based on the latest scientific evidence and nutrition principles of type 2 diabetes management, weight control, metabolic health and well-being. And our clinical research has shown that we've been able to demonstrate that delivers sustained long-term weight loss with superior improvements in blood glucose control and heart disease risk factors, particularly by blunting blood glucose levels after meals, reducing glycemic variability, reducing diabetes medication requirements, and improving blood cholesterol profile. So, oops, let me just, So the question is, that's what the diet is. How did we get to this point, and how does the science support this? So we know the first line treatment for diabetes management is lifestyle modification, diet and exercise to reduce body weight and improve blood glucose control. And we know it's very, very definitive and conclusive that if we can get our patients with type 2 diabetes to lose weight, that we will reduce hypoglycemia and metabolic risk factors. The question that we as scientists always ask is, well, how is this best achieved? There are so many different approaches to this. How might you go about it? And which dietary approach might actually maximize the benefits of lifestyle modification? We know how difficult it is often, and I know we may talk about some behavioral approaches in question time, but how difficult it is to get our patients to follow and adhere to different lifestyle approaches. So why wouldn't we look at what is the options that might magnify the improvements in blood glucose control, which remains a primary therapeutic target? We know that by improving blood glucose control in our patients, we will reduce a lot of the risk factors and a lot of the diabetes-related complications. And we can do this by not only reducing HbA1c, but also reducing postprandial glucose peaks and those hypoglycemic excursions that Alan was talking about, as well as reducing diurnal glycemic variability, which is a very big interest of mine because that is an emerging independent risk factor for diabetes-related complications. And so if we look about how we might then try and change those factors from a nutrition perspective, and I really like to be able to follow Alan because he does all the hard work for me, is that we know that carbohydrate determined by glycemic load has the greatest effect on raising blood glucose. And we know that Alan elegantly told us that that's the type, so the GI, by the quantity of carbohydrate, and that both factors influence blood glucose control and glycemic control. And so there has been a body of evidence now, or a body of researchers that are really interested about, well then, at least in a theoretical sense, if we can lower glycemic load by lowering not only the type of GI, so lowering the glycemic index, but also reducing the total amount of carbohydrate, it actually might be a strong option to reduce glycemic load and improve glycemic control. When we look at protein and fats, when you actually consume protein and fat, that actually blunts the post-eating glucose rises of carbohydrate by delaying stomach emptying of the carbohydrate. And so when you consume protein and fat with carbohydrate, it actually helps the carbohydrate release to slow and therefore limits its impact on rising that blood glucose response. But we know that all fats aren't equal. And over the last 10 or 15 years, we've seen some really good rigorous science that actually shows we've had that low fat message for so long, but I think it's very clear now that it's the fat quality and type rather than the quantity that we should be worried about. And we know that saturated fats whilst they may promote insulin resistance, elevate LDL or bad cholesterol and adversely affect blood vessel function, it's actually monos and the polys that actually do the reverse effect. Actually increasing your intake actually promotes insulin sensitivity, improves your blood lipid profile, as well as blood vessel function. And so that led us to hypothesize at Csiro that if we then devised the novel eating pattern that then limited carbohydrate whilst increasing protein and unsaturated fat, but keeping it nutritionally replete, would such a dietary pattern actually offer patients with type 2 diabetes the greatest improvements in blood glucose control, whilst also simultaneously reducing their cardiovascular disease risk factors? And so we applied to the NHMRC back in 2011, and they actually gave us $1.3 million to do a 2-year clinical trial to actually test this very hypothesis. And so what we did is we recruited 115 men and women, overweight and obese with type 2 diabetes, and we randomly assigned some to what we now call the Csiro low carb diet. So you can see it is quite low in carbohydrate, only 50 to 70 grams, which equates to about 14% of your energy, high in portions of protein, around 28%, and high in fat. But as you can see, we've kept the saturated fat low. And we compared this to what was at the time considered the default dietary guideline approach for diabetes management. So general practice guidelines for diabetes at the time still very much defaulted towards the Australian Guide to Healthy Eating, which based their reference on the nutrient reference values. And they tend to promote that carbohydrate in the diet should be about 45 to 65% of energy. So we ended up at a 53%. You can see much higher in energy, carbohydrate, focusing on low GI, much lower in portions of protein, and much lower a low fat approach. And superimposing this entire dietary intervention, all participants undertook the same resistance and aerobic exercise program. And we measured multiple health outcomes to assess the impacts of these two diets. We looked at weight, body composition, glycemic control comprehensively, looking at not only chronic, but also dynamic markers of glycemic control, traditional as well as novel markers of CVD risk, and looked at a whole panel of other tertiary health outcomes: mood, renal function, cognitive function, bone health. These are all factors that are negatively impacted by type 2 diabetes, yet we don't really have a real grasp on how lower or even higher carbohydrate diets actually impact these particular outcomes. And this is sort of a summary snapshot of the results. So if you look at the two different groups over the 2-year period, we saw similar changes with a lot of the outcomes with both groups. Both groups lost similar amounts of weight. So we were able to achieve about a 7 to 9% weight loss after 2 years, which is a really good weight loss in a diabetic population, which just shows that providing professional support, which the study did, combined with a prescriptive approach, can get you really effective weight loss in this patient population. And with that weight loss, we saw really good reductions in HbA1c. A 1% reduction in A1c is a clinically relevant reduction in HbA1c, and good reductions in blood pressure, fasting glucose, and LDL, or bad cholesterol, and also saw great improvements in mood and quality of life, with no differential changes in kidney and brain function between the two groups. But we saw some really superior benefits in our study of the low-carb diet. We saw a 2-fold greater reduction in medications, which is probably masking the effect on HbA1c, because if both groups had the same amount of medication, HbA1c probably would have lowered greater in the low-carb diet. We saw a 3-fold greater reduction in glycemic variability, which we know is an independent risk factor for diabetes-related complications, and much greater reductions in triglycerides and HDL cholesterol, when we know that high triglycerides and low HDL cholesterol are key diagnostic criteria of the metabolic syndrome. So what we sort of conclude is that we're saying that there's probably no one-size-fits-all approach. I think the Australian Guide to Healthy Eating and the current default approach of a high carbohydrate, low fat diet is still an effective approach. There's nothing wrong with that approach. You can see you can get some really good benefits. But you might give a double tick to a low carbohydrate diet, particularly the particular pattern that we've developed, because it does further magnify those improvements in glycemic control. And so we summarize that the Csiro low carb diet can enhance the health benefits of lifestyle modification and may offer greater therapeutic benefits to people with metabolic syndrome, pre-diabetes, and type 2 diabetes. And this research, as well as combined with a whole lot of other original studies, as well as now very good systematic reviews and meta-analyses, this is starting to advance clinical practice guidelines and starting to make us rethink our dietary guidelines. If you look at now the American Diabetes Association, Diabetes Canada, Diabetes UK, Diabetes Australia, have all in the last 2-3 years have come out with position statements or modified their guidelines to now acknowledge a lower carbohydrate diet as a legitimate and effective approach as part of a personalized strategy for diabetes management. And so what we've done is, in more recent times, is because of the interest in not only these research protocols and these results, we've now translated this particular research piece into a step-by-step guide and publication book series, which is basically an easy practice self-help guide. It contains daily food allowance units that can be tailored to individual energy requirements, weekly menu plans and shopping lists, beautiful recipes, as well as a comprehensive home-based exercise plan, which not only the public are using, but also health professionals are using to prescribe to their patients to get the benefits that we've seen from this particular research. But where do we want to go in the future? So we know that with the clinical research, sometimes, it's very intensive research. So we've done a little bit of work to understand what the clinical impact of providing people the book. And so this was work done by one of my colleagues, Penny Taylor, where we took 20 adults with type 2 diabetes and we actually give them the book without any real professional support in a 12-week intervention. And you can see, even just following the book alone, we get some really good improvements over a 12-week period, a 7% weight loss with about a 0.9 clinically relevant reduction in HbA1c, with good reductions in fasting blood glucose and triglyceride levels. And where we want to move in the future is when you actually give participants not only the book, but a continuous glucose monitor at the same time, so they can actually do some self-monitoring while they're following the intervention, you can see even added benefits with further reductions in diabetes medication as well as glycemic variability. And where we're hoping to do next year, COVID has held us up, is we want to now look at whether this package of care with the Csiro low carb diet plan combined with the CGM monitor can be used as an integrative healthcare model with primary healthcare. And so we're going to deliver this through GP clinics and understand the feasibility of delivering such an intervention through that environment. And my last slide is really just to say where we launched a couple of weeks ago, that we know that the books are fantastic, but they still do require you to cook the recipes and prepare food. And we know that that's not for everyone. And eating habits are changing. Socioeconomic demographics are changing. Single growth of single person households. We're working longer, fast-paced lives. And so we want to make the healthy option the convenient option. And so what we did is we created the Csiro low carb impact mark. And we're using that now as a front of pack labeling system on approved ready meals and meal kits that are consistent with the Csiro low carb diet, working in partnership with manufacturers and retailers. Our first one is an online provider called BeFit Foods. That's their website there. And what we're doing is we're going to now actually stamp meals that are consistent with the Csiro low carb diet, so that these meal products can be used as a meal substitute within the eating plan to make it more convenient, but also will signify to consumers confidence that the contents of that particular meal has a high nutritional quality value. And with that, I'll end my presentation. So again, thank you for the opportunity, Barbara and the committee, for allowing me to share a few moments with you.
Thank you so much for that. Barbara's just had to step out for a moment, but I'm Laura. I'm Media and Communications here at Nutrition Australia, New South Wales. And we have some questions for both yourself and Alan, based on your work, but also as we're kind of looking towards the future of what diabetes prevention and management is going to look like. Earlier this year, we did hear about the development of a world-first personalised nutrition wearable, and this was developed by a Melbourne-based company called Nutrinomics. And this has kind of been touted as something that might help reduce the risk of people contracting diabetes through personalised nutrition. So what we were wondering is whether you can comment on the application of wearable technologies or personalised nutrition in terms of reducing the risk of diabetes.
I'm happy to have a stab first, Alan. So,
Yeah, you go for it.
So
Yep.
I guess, I do know the Nutrinomics group. I've actually done some work with them. Really interesting concepts. And I think that this is the future of where some of the personalised nutrition is going. I think the era of wearables enables actually to bring it alive. You saw in our presentation some of the work that we're doing at Csiro. I think the wearable technologies that actually provide people with real-time feedback about what they're putting in their mouth and the impact that's having on diabetes. I think diabetes for so many years, it's sort of a silent disease that this poor blood glucose control is happening in our bodies. We could never measure it or show it very well to the public. And until their limb was dropped off, they actually didn't understand the impact it was having. But I think that this is bringing it real time. So I think personalized nutrition is where it's at. I mean, even when we talk about glycemic load, glycemic index foods, we all have a personalized approach. And I think by using wearable technologies will help us in the future to then tailor dietary plans, tailor dietary education to meet people's individual needs. And so, yeah, I think it's a really good initiative. It's not, they say it's world class, but I think there's many of these initiatives around the world that is happening, and I think it's a really exciting time to be in nutrition research right now. Alan, maybe you've got something
Yeah,
to say.
a good summary, Grant. I think, I mean, we have wearables now and they're very popular. I think the Abbott one that you stick on your arm and it measures your blood glucose in relative real time, for example, and people with type 1 have continuous glucose monitoring. So certainly for people with diabetes, I think they're fantastic and certainly improving the management of their conditions. I'm not so convinced people without it, because I'm not sure whether they'll be willing to pay the money at this point in time, and it'll probably be the worried well who will be able to afford this, which I suspect is the wealthier people within the community. And we all know very well that diabetes disproportionately affects people from low socioeconomic classes. So whether they will be able to afford these technologies, at least initially, I suspect not. But that, by the way, I think devices that can monitor continuously important variables, glucose being an obvious one. I was thinking it would be good if there was something that could perhaps measure blood pressure for certain people, for example. And of course physical activities, but they don't do all activities. It's hard to get things that measure every sort of activity that we do, but I think it's certainly going in that direction. So, you know, it's good for those with existing conditions where there's subsidies for the test strips or devices, what have you. For the rest of the population, I do think that the price will probably have to come down before those who are at greatest risk can benefit from it, and we have to focus on those. If you look at the demographics of diabetes in New South Wales, it's very clearly the lower socioeconomic areas that are affected the most. So I think we mustn't lose sight of that in the vision of the future.
Yeah,
and just to add to that, I think that's a really good point, Alan. And the wearable costs of technology has come down in some of the CGM and devices, but that's a very good point. And I think what I think is also really exciting about this is how it can help clinicians actually manage patients, because they better understand their patients better. So I think, you know, it's a really application, not just for the individual, but also for the healthcare professional. So yeah.
Yeah, I think that's a really good point. And also in terms of a lot of people who are in high risk areas might also lack access to, health professional and health services as well. So I suppose that's kind of where the recipe book and that kind of approach, the self-management approach that you were talking about, Grant, kind of comes in. So what we just wanted to touch on was maybe what the role of, behavioral change strategies, like how that comes into play with, self-managing and self-monitoring for people who maybe don't have access as much to health professionals.
Yeah, so I mean, like when it comes, sorry, can you just like say the question? So you're talking about behavioral change strategies? Is that what you mean?
Yeah. So what's the role of behavioral change strategies in improving the way that people will follow, for example, the CSIRO low carb diet? So what role does behavioral change play?
Oh, I think it plays a big role. I mean, like, and this is where I think people like, Alan, with their training around, registered dietitians and that, they are so critical to the management of our patients. I know that, people with diagnosed diabetes can get access to these through subsidized rates and other Medicare programs. But it's the training that, dietitians and other health professionals like psychologists that really can help, because I think that has to be overlaid with any dietary approach, whether that be low carb, whether that be high carb, whether it be Mediterranean diet. It really, what we need to do, we know that if we can just get people to adhere to an evidence-based plan, that we're going to probably get a long way to actually achieving success. And to get that adherence, it does require behavioural strategies. And so I'm not a behavioural expert, and I don't want to I pretend to be one. And with the studies that I've done, I actually do them, and they're delivered through registered dietitians, like someone like Alan, who has that training. And so some of the behavioural change strategies that I know that they use are things like goal setting, self-monitoring, which we can now get with some of this health data tracking to support that goal setting. Peer support and social support are some of these other behavioural strategies that you're starting to see a lot more in digital health solutions and digital health programs. Other things that they use is things like motivational interviewing, other cognitive restructuring, where it's involved challenging problematic thoughts and emotions that undermine people's and hinder their success, problem solving strategies. So I think behavioural strategies are so imperative in that. And not only is that's why it's so important, I think, to deliver plans in consultation with the health professional, because they can give you access to those strategies, but you're starting to see a lot more of these strategies being digitized onto health management platforms and diet programs that are available through eHealth. And so, so any good, I guess, any good dietary strategy is going to be underpinned by good behavioural strategies. And so, Alan, you might want to comment on that as a clinician.
Yeah, look, I fully agree with you, Grant. I guess what came to mind, the best diet is the one you can stick to. And I think it's great that all of the major diabetes associations around the world have recognized that. They've dropped macronutrient ranges and what have you, and say, basically work with the individual, their life circumstances, their social background, their religion and an ethnic background, their familial, are they a mother or father, what have you, their finances. All of these factors are important in long-term adherence to dietary advice. And I think, we as clinicians are trying to improve the overall quality of their diet, and that'll have influences on the rest of their family, the people they live with, what have you. So they've got to be achievable. Making small practical changes that are cost effective, that don't adversely affect the quality of the food and their enjoyment of it, will all lead to long-term adherence. And I think that's the important thing, because, without getting too academic, most diets will work in the short term, 3 to 6 months, but by 12 months, people, of course, are really going back to their lifelong habits, because by the time the average person has been diagnosed with diabetes, at least the average Australian's in their mid-40s. So they've had, 45 odd years of eating one particular way, and you've got to slowly direct them, guide them, support them to make changes towards a healthier lifestyle that they, their partners and their family will enjoy. And I think that's where the diabetes management team, working collaboratively, supporting each other, singing off the same song sheet, I think is very important. So not contradicting, and I think there's been various camps over the years that have pushed one way of eating over the other, one diet pattern over the other, and the evidence really does not support that. We should be patient focused and work out what is best for the individual. And that's where maybe some of this nutrigenomics may come in the future. But even if it does, we still have to think about, what can the person, what skills do they have for cooking? What's their budget like? Can they afford these foods? And will the rest of the family support it? So it's really got to be a holistic approach, and behavioural management is part of that. But I don't see it as the be all and end all, because it's not just people failing to be well motivated. It's actually much more complicated than that.
Yeah, and I think personalised nutrition is more complicated than just personalising on one particular aspect, like Alan's saying. Like, some people are going down, we should personalise diets based on someone's DNA. Well, who cares? Someone's DNA might say that sort of diet, but if that doesn't fit with their lifestyle or their family circumstances or even their economic circumstances, that's not going to be the approach. So it's looking at all of those factors, both social, metabolic and behavioural factors, to work with healthcare professionals to find the best solution for you. That's really, I think, what it's about.
Yeah.
And just on that note, I suppose, of, people finding a long-term diet that works for them, we actually have a couple of questions from people who are wondering how participants find low carb diets, how they adhere to them? Is there any dropout issues as part of the study? So I suppose it would be good for both of you to comment on what you've seen in terms of research onto how people actually adhere to low carb diets.
Yeah, I guess a lot of the research that we've done has always been in a very intense context. Like we've always provided a lot of professional support because I'm really interested to understand if people actually do follow a particular diet, what happens to them, as opposed to just prescribing it to them and then letting them do whatever they want. In the research that we've done, we've found that, acceptance and adherence and dropouts are very similar between both a high and a low carb diet. But again, that might be a little bit artificial. But I do know of other individuals that may find it challenging without support to follow a low carb diet, but others that actually find that's the approach that they want to do because they actually get the benefit from it. So as I think we've already talked about, there's no one size fits all, and I think that non-adherence to a diet includes factors beyond the macronutrient profile of a diet. I think why someone doesn't succeed on a particular diet isn't necessarily because of the dietary approach. It may be other factors beyond that. But our experience has been that I think what we're trying to do at Csiro is provide evidence-based solutions, and our experience has been whether it's high protein, low fat, high protein, low carb, whether it be high carb, low fat, that generally we can get good adherence, but that's also with supported professional support. And that's why I can't emphasize enough about we should encourage our patients to actually use the services that are out there, because that's so vital in sustaining their longevity on any particular dietary plan. Alan?
Yeah, so look, I think what the Csiro have done, and I will say, I think it's probably the world's best low carb diet because it has the right kinds of fats. It's actually quite high in fiber, and of course, and I like to point this out when I'm speaking to dietitians. Of course, people saw a dietitian I think 10 times in a year, and all of us clinicians know that you only get, well, Medicare only covers 5 visits a year. So it's a really good advertisement for how it should be done. And if it is done, it produces the results. And I think, you support the people well. What concerns me is that the rest of the bunch aren't necessarily as good. And in the past, they've certainly been quite high in saturated fat. So the cholesterol fractions have not improved. In fact, it's fairly common that high protein, low carb diets, at least in the past, used to lead to aberrations in fat and cholesterol levels in the blood, and that's a problem for people with diabetes, as we know. So I think when it's done well, when it's supported by the team, you get good outcomes. Grant's group has gone out to 2 years, and I think there's still good results in that time frame. Certainly, if you look at the systematic reviews and meta-analyses of low carb diets, they work well up until 6 months, but by 12 months, there are no differences. And I think that's the important thing for us as clinicians. The world that we deal with people living in the community where they don't see a dietitian once a month and the food isn't subsidized, you're not necessarily going to get the same outcomes. And I think we mustn't lose track of that. People need support. And, I've said to my colleagues, I'll say it again, we should be using this data to lobby for 10 or 12 visits to a dietitian a year under Medicare, rather than the 5 that were given for the entire allied health team. It's just not right, because you have very high level evidence that it will help people to adhere to that diet and produce some good outcomes. And as Grant said, it was, on many markers, the alternate healthy diet was just as good. And I think part of it was seeing the healthcare team, getting that support. There was some financial support and food, I think, support at least initially. So all of these factors help with adherence. I don't think we can afford to keep that up probably over a 2-year period in a trial situation, but I think if people were able to see their dietitian 10 times a year, for example, and they see a psychologist 10 times a year, I think it's gone up to 20, and they get paid a lot more. So I think, we need to be lobbying governments to provide that support to our patients, and then we'll help adherence. And I think I agree. It doesn't really matter what diet it is. You can make it healthy by choosing the better quality foods. We all know that Mediterranean diets work well, but also, you know, Okinawan Japanese diets work well, and so does veganism, which is very high carb. So there are many ways of eating well. We need to support people to help them on that journey. And then adherence won't be the problem that I think it is. I think this whole mentality of going on a diet for a long-term health condition is a problem, and we need to get over that.
We're getting some comments through. I agree with you, Alan, 100%. Thank you both. So yeah, I think that's really, really great point, Alan, and it's a really great point to kind of wrap up this webinar on. And I think, you know, a huge thank you to both yourself and to Grant for speaking with us tonight. You know, it's been some incredibly insightful discussion, and I think it's so important to be talking about, you know, all the different aspects that come into play when we're preventing, in terms of prevention or management of diabetes. And I think with that, we've done that really well tonight. So thank you both for your great discussions around that. I just wanted to say, as we're just clicking over past 7 o'clock, I wanted to thank everyone who's logged on and joined us tonight. I hope that you've all really enjoyed it. Here at Nutrition Australia, New South Wales, we really enjoy hosting these webinars and, you know, providing a place for these discussions. So thank you all for being a part of this evening. In the chat box, we will be placing a link for a survey for this. There it is. So you'll see a link for a survey for this event. If you'd like, it's just only about 1 minute, take you less than 1 minute, just to give us some feedback on the night and what you've learned. There's also a link in there for signing up to our newsletter. So if you're interested in any of our future events, just click on that link and put in your email, and we'll be sure to let you know what future events we have coming up. So thank you so much for everyone for being here. Thank you, Alan. Thank you, Grant. Thank you. We're getting some really lovely messages coming through. So thank you, everybody. I hope you all have a wonderful evening and a lovely week. And hopefully we'll see you at another event coming up.
Thank you, Laura and team. Thanks, Grant.
There you go. Yeah, good to see you. Okay, thanks everyone. Have a good night. Be safe.